As you can tell from the introduction, I've been around for a while, and that's where everything comes from. But and as a result of that, I've had a chance to really be able to do a lot of experiential work and seen where it practices. And the thing that we have found out is when it comes to the blood work, we're all taught about teaching by symptoms and working with symptoms and going with that. But what we find with the patients, and our patients too, that if they got a piece of paper in front of them that's got some numbers that they can show to their family or they can show to themselves, they're going to be much more compliant when it comes to treatment. And we realize that there's a cost to this, if you want to use that term, but what we like to do is think about it as an investment in their health, so they're able to better sort of look after themselves with that. So that's kind of where we're at with it, and that's how I put everything together there as well. So we have the disclaimer here. The only thing that applies to here is that RMA is paying me for this particular talk, but all the rest of the work I do with RMA is contractual, has nothing to do with this part of things. But just as an aside, and at the end slide, there is also two things. There's my cell phone number and my own personal email, that if people do have questions about blood work, I know in the past when I used to send reports to you that I would be able to talk to some of the naturopaths, and have done some of that recently as well. But we're available to talk about blood work or any of the other tests that are available too, if you wish to do that. So that's just some housekeeping on our part. So this is our references. One thing that's not in there is one I just came back from. That was in the last couple of weeks. Is actually so new, and some of the information in the talk is from that, is that I haven't even lost my tan yet. So that's how new it is. But these are the references that are there, so some more of the references as well. And again, you get a bit of an idea from this of what we are going to be talking about when we get on to the presentation. So it's a very dry subject, laboratory testing, trying to make it more interesting by putting in some case studies. But the other thing to remember is that you might want to have some water there. The other thing that might help, depending on your time zone, maybe a martini might be good, but in keeping with the situation, please make it a dry martini. Okay, so first patient. This is CU. She was born in '57, and we'll be bringing up with her later as well too. But the first office visit, you can see high stress corporate job, recent significant layoffs, and then as a result of that, more work demand on the people, plus there's new techniques that she was supposed to be learning. She farm stock, so she had this incredible work ethic. So if someone told her to do something, she took it on, but took it on to the detriment of herself. So presenting signs and symptoms, you can see there that the BMI 29, the Apple distribution as well with it, significant fatigue, but you push through because that's what you do. Hard to get up in the morning. Her sleep is very disruptive. She falls asleep due to exhaustion, but will wake up in 2 to 3 hours. Other things that would indicate problems with the cortisol and feeling burnt out, scalp loss. She hasn't had a period for 2 years, but has frequent hot flashes and night sweats, which of course doesn't help the sleep. She also, as you can see here, asthma, musculoskeletal pain, and stiffness, along with other signs of chronic low-grade inflammation and chronic stress, and chronic sinus and ear infection. So we've got an inflammatory picture going on here as well too. She did grow up in a dairy farm, still consumes copious amounts of dairy on a daily basis, which we all know can contribute to issues as well. So what we did with her is we did the Healthy Enhanced panel with some of our own add-ons. We suggested the female saliva test panel with the 4-point cortisol, which she did, the food sensitivity 120 plus candida, which we always do when we do the food sensitivity, and the ultrasound. Her concern when we did the food sensitivity was that she was going to find out that she couldn't have dairy anymore, which she said would finish her life off. And as it turned out, she can't have dairy anymore, and but she is still alive. So that part is good. So moving on here to the to the next one. So this is a quick thing. We won't go over this because of the time constraint now, but inflammation is the smoking gun of all chronic illnesses and acute illnesses. And it is so, so important that it's important for us, and this is what I do when we're looking at the testing, is looking at patterns, but we're looking at how much inflammation is going on, because we know that if we can get that early, we're going to make a big difference on people long term. So instead of waiting till they get the pathology. And the inflammation, the cortisol response is great for short term, back to normal, but for chronic long-term stresses, it's not. And we can see here that the long-term cortisol, eventually we're going to end up with insulin resistance. We're going to end up with obesity. We're going to end up with metabolic syndrome and a decreased immune response. And then the pathway is set for her. And we'll see how that plays out later when we get into the little part on the non-alcoholic fatty liver disease as well too. And again, when we just came back from the talks, I mean, they're very medical, so they're very much into drugs, but they did talk about the importance of inflammation as getting people to that. Unfortunately, with the work that you guys do and that we do, we are able to work on that inflammation. We understand the importance of it. So the most sensitive ratio thing for picking up inflammation is this arachidonic EPA ratio that's there, and that's a very, very important marker. And then other ways of assessing silent inflammation, and you'll see how they come up. And there are good numbers and there are ideal numbers, and then obviously there are bad numbers as well too. So this is just a graph for you to look at later, showing what would be considered good, ideal, and then the marker. But time you get to good, as you can see, you've gone above ideal already, so you're already in a physiological and a pathophysiological change that's there. So our goal is to try to get them down to that ideal as much as we're possibly able to do. And that's again why doing the blood work, doing the other tests, but doing the blood work, people can see the numbers. You can say to them, okay, this is what's happening, inflammation is here, this is the long term, because we know that the genes are how we got here, and that's our genetic destiny if we epigenetically will turn those genes on or upregulate them, downregulate them. And unfortunately, again, epigenetics is such an important way of being able to change gene expression, and we know how to do that. So again, about insulin and the importance of it, you can see here the visceral fat that is there. That's the APRIL profile. Remember our patient, BMI 29, APRIL profile. But this visceral fat is very active metabolically, and we get a continued arachidonic release, acidose release, which therefore is a continual underlying inflammation going on, as well as the visceral fat releases other pro-inflammatory mediators as well. So taking our lifestyle, taking the patient's lifestyle, you can see here the recipe for belly or visceral fat, cortisol, sugar, and starches. I think that sounds like the majority of patients that we all have there as well too. So again, how do we follow up? You can see what we look at with there, but the big thing is this lifestyle platform is our treatment plan. The problem is people really aren't that interested in lifestyle, unfortunately, but it's something you can do. And again, having the blood work done, having the test done, you're able to point them and say, okay, this is it. And in my experience, if we don't do something to enhance the changes here, this is where you have that potential of ending up as well. So this fits that very well. The topic says lifestyle changes are essential for complete and permanent healing. And the two guys at the bar, one says, my doctor told me to change my lifestyle. And we've sort of alluded to this as well, that the autonomic nervous system, when we're in balance, everything's in homeostasis, equilibrium, and balance. And what happens is with the triggers, the epigenetic triggers, we start to move out of balance. And as you can see, what happens is we get a new norm, and instead of going back, people are sort of moving forward. And by the time they get to us, symptomatology is what we're seeing here. And that symptomatology is what the patients notice. our thing is we have to be sure that, remember that symptomatology is where that's the body showing us there's some dysfunction going on. What is underlying here? We don't want to just try to cover that up, because we know that if all we're doing is covering it up, we're going to end up needing another treatment or another drug, because we're not doing anything about it's there. So again, keeping all of this in our mind when we're looking at the blood work helps us to be able to enhance our discussions with the patients on where do we go from there. And of course, stage 5, not really the place that we want to go to. So this was said in 1977 or 1777, that in the beginning, disease is difficult to recognize but easy to cure. This would be stages 1 and 2, maybe partly into 3. In the end, disease is easy to recognize but difficult to cure. So again, just a reminder that we have to go to the beginning with it, and that's how we're able to do that, is by putting all of these pieces together, the history, the symptoms, as well as the blood work. So Thomas Edison said the doctor of the future will give no medicine, but will interest his patients in diet and in the cause and prevention of disease. But is it getting there? Probably not, because this is today's medical paradigm. It said people are fed by the food industry, which pays no attention to health, and are treated by the health industry, which pays no attention to food. And we saw that in the conferences that we went to as well too. It just didn't get it. But again, we all know the importance of this as well. So again, the Enhanced Healthy Living Assessment Panel. Time for that next drink of whatever beverage it is that you're having as well too. So back to our patient. Again, the important things here, as you can see, the inflammation was there, the obesity was there, or the overweight was there, so the inflammation was present as well. So what we've done here is we've shown you what can be done and the benefit of the test, because she came in, family history of diabetes, afraid that she was going to be getting it, had been tested by other people. And again, in our practice, we don't take anyone on their own. Everyone has their own family doctor. We just take them on for those who want to work in the way that we work with and as an add-on to what they're doing. But when she saw these numbers here in October 2014, for her, this was important. It got her attention, and you can see here fasting glucose 15.7, A1C 9.6, fasting insulin 124, and again, that's good, but ideal would even be better. And then the HOMA2IR. Now the HOMA2IR is not a test, it's a figure, and I don't know how many people are using it. I know we've talked about it before, but we'll go to the next slide. If all goes well, we'll be able to go back to that again. But it's a graph, and again, this is not this patient, but it is actually a real patient as well, who had been tested by their doctor and said that they were okay, but a BMI was actually about 37, I think, on this particular guy. Fasting plasma glucose was good. His hemoglobin A1C was 5.2. But you see when you put these numbers in with his insulin, how high that was. So the insulin resistance was there, and you can see that the IR insulin resistance was 6.3, and down here you can see where the accepted is greater than 2.6, highest specificity is greater than 3.8. So we just keep those in mind, but when you get above 2.6, you got potentially probably got some issues. When you get above that, guaranteed, and obviously he was here. This is a download that you can put on your computer. Works really, really well. We used this on our patient, and that was part of what helped her as well too. But this is the download, and also just gives a little bit more information about it as well too. So we'll go back again, if I can do this. Okay, so there's our patient again, and you can see her HOMA-IR was 3.4. and then came down to 2.3, 1.7 as she followed her lifestyle. Triglycerides. Again, sugars and fats, the first fat that is produced when you get an overload of glucose. And so you can see it was 2.39. We like to see it less than 1. And just a caveat here, remember cholesterol at this moment, they're not using fasting, but triglycerides has to be a 12-hour fast to get a proper number. So that's something to remember about. And the same thing with serum iron when we get to that. That's got to be a 10-hour fast as well too to get the proper number. So those are two pieces of important lab information that aren't always followed. That's there. And again, the triglyceride HDL ratio, again, less than 1. You can see the trend as we go to the other end. She is really watching herself. We also worked with her on meditation, heart math, homeopathic remedies, all sorts of things to try to help her to be able to handle her life better as well too, because there was more going on in her life than just the environmental triggers as well. Highly sensitive CRP, 5.2. And again, when we do the testing, instead of just doing the CRP, we usually do the highly sensitive because, again, it is more sensitive. And you can see the trend going down there as well. See here, the 2 liver tests are elevated. ALT less than, or should be less than 40. We know there's something going on in the liver. We know the importance of the liver. That's what prompted us to do the ultrasound, and she did actually have fatty liver, which we'll get to later. GGT, very, 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 very sensitive liver test. The hepatologists actually don't like it because it's too sensitive, but in the last conference we were at, they said that those who have an elevated GGT have an all-cause mortality increase over those that don't. So it's a very, very good test for us to be able to be doing so that we can, again, look at that. And if it's up, we know that we've got to do some work on the liver. We also know that we've got to be working on the inflammation. Vitamin D, she thought she was going to get all her vitamin D from her milk. Obviously it wasn't working, and you can see we got her on some vitamin D and things did improve as we went along, and we'll have a little part on vitamin D too with our normals of where we want to see. So that was basically where she was at, and the trend gave her the opportunity and gave us the opportunity to be able to say to her, it's time to do some moving here. Okay. So back to that, we'll move on. So again, this is another lady. We'll just go through her quickly with it, but BMI of 33, clinically hypothyroid, mildly hypertensive. She just couldn't do anything for herself. As you can see here, she couldn't give up that programming no matter what we did. She'd have moments of trying, but as soon as she started to feel a little bit better, she would sabotage herself. And again, just to show another part of things here, you can see that when we saw her, first of all, in 2010, these were her numbers. She was able to get it down to this, and then would kind of come and go. Blood sugars would float around, or thyroid would float around. She just really wasn't that reliable. But we're seeing the trend here. You can see her blood sugars haven't changed that much. But what we are seeing, her fasting insulin was up. In July it went up higher. And if you just took this, you say, oh, this is good, her insulin's come down. But her sugars are still up, insulin's come down. She's now exhausted her pancreas. And that's where she's at. You can see here the microalbumin as well. So this is a lady that pushed it, and she's now on medication, still not looking after her diet, still not looking after anything else, but that's where she's at with it. But again, looking here, and this will come later, white blood count, neutrophils, you can see how with chronic stress over time they change. And so we'll be seeing that later as we get into that as well too. So again, just as a summary, these are the sort of the things that we look at that are important to give us an idea of where we are with insulin resistance and with our glucose metabolism. Again, this is not something in the test, but you use the panels to be able to give you that kind of information that's there. So specific areas of interest. We also look at, besides the fasting insulin, the triglycerides, we look at this spread. Remember that guy with the HOMA-IR thing that we did? His glucose was 4.8, A1C was 5.8. And so you can just, when you see a huge spread like that, you know that there's some problem going on with the carbohydrate metabolism. And generally, if we're seeing the A1C being way up there, we know that we're looking at some insulin resistance issues as well too. So again, a big thing there with everything, not just the white count, which we'll get to, but the iron and the iron stores, which are a little bit difficult sometimes to ascertain. We do have a patient there that is going to be able to give us some really, really good information as well. So iron stores and ferritin, when we do them both. And the reason for that is because ferritin is really good if it's really low, as far as knowing that they've got an iron deficiency. However, if it is high, it may not mean that they're okay with their iron, it just may mean that they've got a lot of inflammation going. So again, when we do it, we look at those numbers as well too with the iron stores. So this is a patient, and this is a very dramatic patient, but it'll help you sort of see the pictures of her. She presented to the office with extreme fatigue, a history of heavy periods, and known fibroids. Wanted to do everything naturally, so that's why she came to us. But this was her presenting blood work that we saw. So you can see the hemoglobin, 72, way down there, hematocrit, RBC, everything is low, MCV. And in this case, the MCV is low, which we expect with an iron deficiency anemia. And her B12 was very, very good. It was actually high, which is why the MCV actually is so low. Because sometimes you can get a mixed picture and you can see an iron deficiency that's down there, but it may be in mid-range. The MCVs may be in a mid-range because of the fact that they could be looking at some B12 stuff as well too. So you have to kind of look at it. RDW, which is the width of the cells, 16.4%. Now this goes up when we are looking at an iron deficiency anemia. It actually does go up with B12 and folate anemia deficiency as well too. So it's kind of if you can see a pattern or trend with the person, it's one of the earlier ways of being able to detect, and also very much so with blood loss, to kind of get a sense of where they are with their hemoglobin and their iron stores. Ferritin less than 5, and again, stores. So this place, the ferritin actually worked very nicely because she really didn't have any other inflammation that was going on with her. So again, just a reminder here, 10-hour fast is the important thing that we need to know here. And again, transferrin is a protein that's made in the liver. So we've just put in here, and this is for your perusal later, some of the things that can elevate the transferrin levels. So it can give you can have a high transferrin, but maybe the other numbers are lower. So it's sometimes hard to sort of ascertain a little bit of what is happening. But this will give you an idea of knowing if the transferrin levels are higher. This gives you some indication of when you have a decreased sort of transferrin, but you can see that it's in a negative acute phase reactant, so it will go up, it will be decreased with inflammation, and then the sickle cell anemia, etc. So again, continuing on with this, your saturation is going to be there, and it's going to be increased with these different things. And you can see here it goes up with your iron intake. And this is why it's important to do your 10-hour fast, because if you had an iron-loaded meal before that, then what's going to happen is they could look like they've got a lot higher iron than they do. So again, to do it properly, you need the 10-hour fast that's there. And then you can also see there the saturation as well too. So ferritin, we've talked about it. Again, if it's low, it's one of the most sensitive tests to look at that iron deficiency anemia. If it's elevated, these are the things that can cause it. Alcoholism, basically things of inflammation, and a fact, again, a reminder that it is an increased and chronic inflammatory states as things that does put that up. So getting back to the special areas that we look at when we look at a CBC and we look at the MCVs, again, these are the numbers that we are looking at. And again, RDW does give us some pretty good indications as well too. White blood count. Take a drink. You can see, and we know this, what causes it to go up: inflammation, dehydration, etc. It'll be decreased with overwhelming infections, chronic stress, and again, in older people, sometimes their immune system is such that they do not increase it even when they're quite acutely infected. But this one here, steroid use, this happened to us in our practice. We had a lady, actually got a really neat lady. She was 78, marathon runner, couldn't wait till she got to 80, because when you get to 80 is a new class, and usually often you're the only one in it. Sometimes there are a couple, but she said it was great because you could either get a gold medal or at least you'd be in the top 3. So that was her goal. But she came to us with chronic lymphocytic leukemia, that white blood count and lymphocytes were just slightly elevated with her. We went back, looked at her past, did a lot of drainage, cleaned things out a lot with her, made some changes with her lifestyle, and we did get her to the point where we were able to get her white count and lymphocytes just into the top end of the normal. She always did blood work a couple weeks before she came to see us, and we saw her blood work come by, and her white count was 30,000, lymphocytes were 15,000. And we thought, oh my goodness, she's made that transition. When she came in, she looked great, felt great. Turned out that what happened, a week before she did the blood work, what she ended up doing, she had some problems with her hip, didn't want to stop running, went and saw somebody, and they gave a steroid injection into her hip, and that made that increase significant like that with her. What we did find with her as well too, unfortunately, it took about 3 months to bring it down slowly because of the repository of the steroid in the hip. But what happened was we never did ever get her again below the white count below normal, and her lymphocytes down into the normal range as well. So it just shows how these things out there can be a factor. So you really have to check with your patients and find out. Okay, liver digestion. These are the sort of main areas, we all know about them, of what we're looking at when we're doing things. But again, with the talk that we just were at, the non-alcoholic fatty liver disease, and this is something which is really becoming much more prominent now. You're probably seeing more and more of that in your practice as well too. It's increased as a result of the obesity, and you can see here obesity creating visceral obesity, metabolic syndrome, insulin resistance. So the whole obesity thing is that's allowing this non-alcoholic fatty liver disease to show up, and that's what they call it now, NAFLD. You can see the other initials here that will come up with our next slide as well, but just so you get a sense of what it's about. But in the last one, he finally said that and you'll see this in the slide, what causes them to move, and what causes them to move is inflammation. And I remember when we were in Ontario, many years ago, unfortunately, what we did find was when people did have fatty liver, it was primarily due to alcohol. And then toward the end of our practice, we were starting to see people with fatty liver showing up that we knew, because we knew the people that were not drinkers. So it was starting to show up then, and it's just the last 10 years it's really increased. And they've done autopsies for other reasons on kids who are 10, and they're finding fatty liver disease present in those. And not a surprise, really, when we look at everything that's going on as well too. So this is the just sort of the logarithm, of the fatty liver. But you can see here that the majority of them, that's about 70%, will just go to isolated fatty liver, no risk of going into fibrosis. But if you add inflammation, These are the ones that then will move down into the non-alcoholic steatohepatitis. Some of them will go directly if there's a lot of inflammation to there. If it continues on, down to cirrhosis, and then moving up to as more and more fibrosis occurs, the hepatocellular carcinoma and decompensation occurring. So it's an important thing, but again, the importance of inflammation is what triggers this to move on to more disease. Again, on our pathways there we had of 1 to 5, it's the inflammation that continues to move people further down onto that. So when we do the liver disease, liver tests, a couple things are of specific interest. The low GGT, again, we mentioned it was a very sensitive test, but it requires magnesium for the test to work. Isn't the best to correlate with symptoms, but we have found this very well correlated, that if we've got a low GGT and the magnesium symptoms that are there, get them onto some magnesium, things can improve. If it's elevated, chronic alcohol detention, and it's the most sensitive test for biliary obstruction. The ALT-AST ratio, you're very aware of that. And then we look at it, is there some isolated tests increasing? Is there bilirubin increasing? What's the story here? Put this in because it helps when you're looking at alkaline phosphatase and combining tests to give you a better indication of where the disease is, like whether hepatocellular, whether we are looking at more biliary tree. And also with the alkaline phosphatase, as you know, it does come from liver and bone. There are isoenzymes available that can help differentiate if you're not sure. But when you put that with liver tests and the alkaline phosphatase, it is a really good way of kind of getting a good view of what is going on, with the patient as well. Okay, so that's liver. We're going to now move on to the lipid and cardiac profile. And we've talked a bit about it with the triglycerides and with that one patient before. I think the important thing here is you need to know that we have to know all the lipids. It doesn't do any good just to do cholesterol. We don't know how much is HDL, how much is LDL, how much is, sort of oxidized LDL. So again, looking at the whole profile, and just again that reminder, that 12-hour fast to assess the triglycerides, and again any alcohol in the previous 48 to 72 hours can increase it. Lipoprotein small a is a real marker of inflammation. We found it with a lot when we were doing food sensitivity tests with people, that a lot of the external inflammation is the triggers or the things that cause that inflammation. And so getting rid of some of that inflammation, especially the foods, we found that we were able to bring those numbers down. But as you can see here, when it is increased with estrogen depletion in menopause, and again, much more difficult trying to get that down in the menopausal woman without knowing where they were with their estrogen. And again, that's where the food sensitivity symptom or tests can come in to help us as well. Homocysteine is something that we do include for a couple of reasons. It's a soft marker cardiac-wise in the medical field, but it does give us some idea of how well they're handling inflammation, how much inflammation is there, and it does give kind of an indication of what are the methylation pathways, how are they doing. So if we've got high B12 or quite adequate B12 and high homocysteine, it does make us think that we are looking at possibly a methylation issue as well. And this is important, of course, because estrogen needs to be methylated to get out of the system properly. So if you've got a methylation issue here, you need to be doing the testing and the Chi testing, which is going to be coming sometime, I understand, in the next 6 to 8 weeks, to be able to see how the methylation is doing, so that we're helping to get rid of that estrogen burden in the patient themselves. And again, the highly sensitive CRP, we tend not to do CRPs we always do the highly sensitive one because, well, I guess it's more sensitive, so it does give us a much better idea of what we're looking at. Some of the other apolipoproteins, ApoA related to HDL actually goes is down in with people with progestins, not progesterone, but progestins. ApoB actually goes up when people are on progestins. So you can see there the impact of the synthetic hormones and the progestins with respect to cardiovascular disease as well too, and especially if you're giving these things by mouth, huge impact through the liver on the cardiovascular system. Again, some ratios that are there. ApoE, we threw that in there just because of, again, the reminder of, there's the genetics are there. If you've got this allele with both E4s there, then people say, okay, you've got a much better chance of having Alzheimer's disease. But really what is really the back of it is high levels of oxidized LDL and associated with Alzheimer's disease, but all the other neurotoxic diseases as well too. So again, we're looking at toxicity, we're looking at the inflammation from that toxicity as well too. So again, back to the specific areas if you're wanting to look at things. This is an interesting ratio here. Triglycerides, again, make sure it's a 12-hour fast, and HDL, that's where we like to see it. And it's kind of a poor man's test for testing for particle size. It gives you a bit of correlation that the lower the ratio, the more we're looking at the beach ball fluffy type of LDL particles as compared to the small dense one. The higher the ratio, the more we're looking at the small dense one. Obviously, ideally, do the particle size, but this is a way of giving you an indication of where the patient could be going. And again, the ratios that we like to see as well too. Okay, so just a couple of caveats here. Cholesterol, as you all know, varies, but this one here, MI, you can decrease the levels by up to 50% for 6 to 8 weeks after the MI. And this happened to us in our practice. We had a patient who had been following with us, knew that his cholesterol was up, triglycerides were up, very busy guy, didn't really want to follow things too much. About 5 to 7 years later, ended up with having an MI. Fortunately for him, he was about 1 kilometer from Foothills Hospital here in Calgary. Got in, had a 99% occlusion. They ended up putting a stent in him, etc. But they told him that cholesterol and triglycerides were not his issue. They didn't know why he had had this, because his cholesterol and triglyceride numbers were normal. But what was happening was it was this that was impacting him, because once he got out of the bed and we saw him 3 or 4 months later, did the tests again, those numbers had gone back up again. And his wife was a nurse too, which really confused him. And again, information about the triglycerides there as well too. So we talked about vitamin D. It's been in the news lately with the toxicity, but this is the range. We'll show you why we got to this range here. But, excuse me, this is how toxicity appear. But in our experience in clinical practice, that we have found that people need a D3 level of somewhere between 4 to 5,000 international units per day to get up into this range. And we don't see toxicity. We haven't seen it getting up there as well too. And fortunately, with RMA, you are able to do the vitamin D levels so that you can really monitor them and see how people are doing with that as well. So it's a great test to be able to do because of the importance of vitamin D. And as you can see, all of the different places where vitamin D can function in, it appears that there's probably vitamin D receptors in just about every cell of the body. So if they're there, there's a reason for that, for them to have that. So percentage, these are retrospective studies. So these were done in the past, as you know. They've taken the studies, looked at the vitamin D levels, and looked at the changes of these particular diseases. And here, these numbers in parentheses are the ranges that are being transferred to the nanomole per liter levels. So you can see the difference in the ranges for the different diseases or problems. You can see this as well too. But again, vitamin D is just part of the picture, but it is an important part of that as well too. And there were studies taking that, 8 of them did show toxicity, but according to Hathcock et al., there was no toxicity if the levels were below 500 nanomoles per liter. And you can see how much vitamin D a person can synthesize in the sun as well too. And just as an aside, this is a pretty good download for converting from international or from the metric to or the SI to the imperial or vice versa as well too. So thyroid, another area that is hard to understand. It's not well, and especially not in our experience in the medical field. We have a lot of people coming to us that are not feeling well, that have been on medications, that have mentioned that they're doing, their numbers are good. So when we look at it, this is the ranges of the numbers that we like to see. So, and we like to do all of these tests, especially on the first time we see people, because we want to know, do they have antibodies? Have they had thyroiditis or some kind of inflammatory disease in the past, or is it still going on? And is there any indication there that could make us think there could be some thyroid cancer going on as well too? Because if
Hello, everyone. We're sorry, we're experiencing some more sound difficulties here. We'll just be troubleshooting for a second, and then once we get back on, we'll get Dr. Westmacott to review the thyroid panel ranges again. Hi, Dr. Westmacott. Do you mind reviewing the thyroid panel again?
Okay, the one that we've got up there now? Yeah.
Yeah.
Okay. So just as a quick review, then I guess we lost sound there. These are the numbers that and the ranges that we like to see, because you have to remember that there's optimum range and there's laboratory range, and laboratory ranges are based on bell curves. And as we all know, with the bell curve, they're going to be people in there who are going to have abnormal tests because they are subclinically ill. And so if we go by the laboratory ranges, we're going to be missing a lot of people. That's why we come up with, and these optimal ranges are there. But the important thing with this is looking at those ranges. And I said with the antibodies, what we like to do is we want to know whether there are antibodies, because it helps us know whether they're going to have maybe people who may have trouble converting T4 to T3 later on. Also, if there's damage going on, then already in the cells, it may be that there's enough damage in spite of what we're doing to try to improve everything and get rid of the inflammation, that even with the antibodies coming down, there may be enough tissue damage that they still may need some amount of thyroid hormone as well treatment. Other important thing, and when we treat thyroid, we always treat adrenal, because they're so interrelated, and sometimes the thyroid gets blamed when it's actually an adrenal issue. And if you over-treat the thyroid, that can be a stress which can shut the adrenal down. So it's an important thing to remember that never treat the thyroid without making sure that you're treating the adrenal as well too. So this is a patient, and we'll go through this quickly because we're running out of some time here as a result of everything, but she had a total thyroidectomy for Graves' disease, age 15. On Synthroid, piles and piles of stress in her life. So her TSH was always low, which it does when there's a chronic stress going on. But the other thing that she was never told was she was not told that she shouldn't take her thyroid medication before she does the test. because if you take the thyroid medication before you do the blood work, and do the blood work a couple of hours later, you're going to have abnormal numbers. They're going to look a lot higher than what they are, and of course the TSH is going to go down. So when we have people do the blood work, we have them do it in the morning, even if it's not a fast. We'll do it in the morning before they take the medications. And this also applies to vitamins, because if they take their vitamins and they do blood work a couple of hours later and you're testing for that particular vitamin, again, they can look much better than they do. So it's something that patients always forget, but we have to remind them of that. So you can see where she came in, TSH low, free T4 was high, but no one had ever done the T3s or the reverse T3, and you can see where she was with the reverse T3, so we see where her antibody was. And as I mentioned, we don't take people on directly, so she had started on some desiccated from her family doctor, and this is the regular desiccated with the rapid release. Again, did not take her blood work before the medication, and you can see the numbers that are there. So with work with her and trying to help her not to be her own doctor as far as her medicating, you can see where we are with her now. TSH is still low, but the stress part hasn't improved. And you can see this is where we have her on some of the PCCA, slow release thyroid, 75 milligrams in the morning, 20 milligrams of the IR in the morning, and then 20 milligrams at 1400 hours. And she's feeling better than she has ever felt before. So it's just a matter of really working at it, playing with it, and listening to the patients, but also treating the thyroid at the same time as well. Another lady, and this is a conversion factor here, where she was not converting her T4 to T3. And again, her numbers, TSH and free T4 numbers were good. She was on high dose of Synthroid that kept increasing it up. So we were able to assess that, worked with some of the things to help with that conversion, but we also ended up getting her on the slow release thyroid, and so she's doing much better. But she had adrenal stuff, so we needed to get her on the bioidentical progesterone as well as adrenal support, not cortisol. We can do that, but we didn't need to do that with her as well. So again, the specific areas of interest, you can see what we look at when we're doing it, remembering that the antibodies are very much impacted by gluten. We've seen antibodies come down just by getting people off of gluten. And of course, improving their inflammation as well too. So this is an excellent article. You need to get it if you really want to understand what it's about. It's all about the deiodinization, and we won't go through. We're going to have to go through this fairly quickly here, but just to let you know that you can't rely on the TSH, especially if there's stress that is there. You can see here the differences. The pituitary has different deiodinases, and it behaves differently with the D2 one. And so when there's stress going on, it will look like it's got lots of thyroid hormone, and so therefore will drop the TSH, whereas the body will not be converting, and it will not have the T3. And so you'll see that in your patients as well too. And again, the deiodinizations, but remember, this is one of the things that helps with conversion, decreased in women as well too. And also D3 converts the T4 to reverse T3, again activated during stress as well too. Some of the conditions that impact the deiodinized activity, you can see them as all things that we know affect thyroid, but it's related to the deiodinizing. This I call my sedative hypnotic slide. This is one guaranteed at 3 o'clock in the morning to put you to sleep, but it just kind of puts it all together so you can kind of get a better picture, because if you can have a model in your head of how this works, the blood tests and the results are going to make a whole lot more sense to you as well. And some further testing, iodine ratio, urinary iodine, 24-hour thyroid assessment. These are all things that we can be doing there as later as well too. And again, what happens? They feel better with T4, and it's because they do feel better, but then they start converting often into more reverse T3, or they're not converting into the T3, so they feel better. But again, remember this part, you can shut your adrenal down if you treat it inappropriately without supporting and treating the adrenal as well too. Antibodies that are present in the different thyroid disease, so you can see that they are present in both things as well too. Again, something to look at later. Now the prostate. I know that we were told lately that you don't need to do PSA. The last talk we did, or not talk, but a conference we went to in March, put on by the Mayo Clinic, they're using PSA, but they're using it more than just PSA. Actually, the committee that decided they didn't need PSAs was a committee of 15 people. There was only one oncologist on it. There was no urologist. It was all basically lay people and internal medicine people. So it's just kind of interesting. But these are some of the things that can increase your PSA. So you have to be aware of that. And you can see here things that can also increase it. So if you're going to be getting people to do it, you want to make sure that they're not anywhere near the timing that's in here with any of these particular kind of tests. But what's important, you can get this from work, is the PSA velocity. So you can see the changes. So the change in a year if they have the PSA of less than 4, if they have a greater change of that PSA, they have a poorer prognosis than those that don't. And again, if you have a PSA of 4 to 10 with a velocity that's greater than that. So that is an important way of putting the PSA together along with your rectal exam as well, not just looking at PSA by itself. And again, you can see the percentages here of free PSA. So again, this test is available to you. So if you put this together, then again, you get a much better clinical picture of what is going on, with the patient as well too. And again, different ages, different numbers that they put in, and different ethnic groups also have different numbers as well too. Okay, these are individual tests. They are available to you individually. They're not part of the enhanced panel. But the important thing with them, because you get patients asking for them, is to remember that cancer markers are antigens. Okay, so an antigens means that there's been inflammation. So all of these are increased with inflammation. So the patient may not have cancer, and that's the reason why they're sort of not in favor in the regular mainstream medicine, is because they don't have a cancer present. But if they're elevated, they're not just elevated for no reason at all. There's where they sort of come in. You can look at that later as well too. And then these are other tests that are available through Rocky Mountain, and we find them as a great adjunct to what we're doing. The blood work gives us a lot of pathology. You put the patterns together, you get more of the physiology. But if you can do that with these other tests, then you really do get a chance to get a good picture of where the patient is. And if you get a good picture where the patient is, and you can show them that piece of paper, it's amazing how much more compliant they will be as well too. So just a quick thing. This is the fatty acid profile that we see on a patient. This is when they were doing EPA DHA 1440 milligrams. You can see the number there, the ratio. You can see it's not in the optimum, and that's actually the number there of the ratio that what they were on. So the patient doubled up their EPA DHA. You can see it has improved. It still could go better, and you can see the ratio. So again, it gives you an idea of this, and remember we mentioned right at the beginning the importance of this ratio with respect to inflammation. So it's another way of kind of assessing how is your treatment doing and how is the patient doing as well. This is the urinary thyroid, and you can see here the T3, T4 ratio was below the range, even though the T3 and T4 numbers were normal. And again, you can see the ratio, you can see where they are. So again, these people were not converting properly as well too. Urinary iodine plus, again, really good way of being able to assess where the people are with respect to their iodine. You can see this person's in a moderate deficiency, and you can see how it's broken down here. This is a person here that you can see excessive. See, all the numbers are up there. She actually was supplementing iodine on her own, but didn't know how much to do. So by doing the test, it gave us a chance to see, because again, too much iodine can be a factor with respect to inflammation of the thyroid, and obviously none of us want that as well too. So, question, with saliva testing or blood for hormones, dried spot, 24-hour urine, and again, Rocky Mountain, the Chi test, as far as I understand, is supposed to be released in 6 to 8 weeks, so that'll be great to have that. There's some incredible information on that test, so that's definitely one to be waiting for and working with your patient as well. So this is just a graph here that gives you kind of an indication of what you're looking for and what you will find and what the numbers will be. So if you're trying to assess, should I be doing blood work for this, or should I be doing a saliva test? What should I be doing? This graph can give you an idea of, so you can get your most bang for the buck, and obviously for the patients, that's what they like as well too. Okay, so we're at the end here. Just as an aside, we can do all the work we want to do, but I think the thing we have to remember, and this is combining genetics with epigenetics, taken together, factors such as the food we eat, whether and how we exercise, the way we give voice to our feelings, the attitudes we hold, how much of our story we're able to let go of, how do we give back to our specific world, and the quality of the environment in which we live, physically, emotionally, and mentally, are far more important to the quality of health than even the most sophisticated medical technologies and treatments. They give us an idea of where we're at, the testing does. Then what we can do is put together everything that we know so that we can work with the epigenetics, so we can change how the genetics express themselves, so that we can make a difference on the expression of the quality of disease or the quality of life that the people have. So remember, we can learn this from our children. They're the ones that epigenetically are going to be doing very well. So it's an important thing for us to remember to have that in our lifetime as well, and to lighten up with everything as well. So again, this is the end. It's our goal. The doctor says, you have a rare condition called good health. Frankly, I'm not sure how to treat it. That's where we want to go with it. And we definitely appreciate you attending this now and in the archives. And again, just as a reminder, these are the contact numbers if anyone does want to contact me anytime when you're doing blood work or tests with any of your patients, because we're able to put together the both sides of the picture as well too. And you just give us a call or an email. We get back to you, set up an appointment, phone call to go over that, and things go there. So again, thank you so very much, and we apologize for the technical issues, but I think we managed to get it within the hour, so hopefully things are good for you. Take care.
Thanks so much, Dr. Westmacott. We really appreciate this great presentation. Also, for more information on the patient assessment panel available to you, please contact your territory representative, or you can email webinars@rmalab.com. That's webinars@rmalab.com, and we'd be happy to provide you with more information if you would like further details on conventional testing. Also, if you have additional questions after the webinar that you would like answered, you can either email them to webinars@rmalab.com, or you can contact Dr. Westmacott directly using the info included. Thank you so much, everyone. Have a wonderful day.